Good evening, everyone. We'll be giving about 5 minutes for majority of our colleagues to join into the CME session. Kindly be patient with us. Good evening, everyone. Once again, welcome to today's CME session. We'll be proceeding as we wait for a majority of our colleagues to keep joining in and logging into the session. Kindly welcome. So today's session is about optimizing progesterone therapy in modern gynecology. And we've had a number of talks in the recent past, in our recent sessions, about progesterone therapy. So today what I would like is, rather than going over the basics, I'd like us to take this conversation a step further. What I'll be expecting to hear from our speaker is, who is the right patient for progesterone therapy? Which progesterone preparation would be ideal for the lady? What is the appropriate dose and route, and for how long should we put our pregnant lady or our lady, gynecologic lady, on progesterone therapy? And most importantly, I would like to know, are we using progesterone because there is evidence that supports its use, or sometimes it's simply because it's become part of our clinical routine? And these are some of the questions that I'll be expecting to get an answer from as we explore today's session. With that, I'd like to invite our speaker for today's session, Dr. James Amenge. He's a consultant obstetrician and gynecologist at the Kenyatta National Hospital, and also an adjunct lecturer at the Faculty of Health Sciences at the University of Nairobi. As we go along, please post your questions and comments on the chat box, and we'll have as many of them addressed during the discussion. With that, Dr. Amenge, welcome, and over to you.
Thank you so much, Dr. Evyonne, for the elaborate introduction. And thank you so much, ladies and gentlemen, colleagues, for joining despite the late hour for us to share. Of importance is that this would be more of a conversation. For the things we are going to discuss are probably some of the things we practice nearly every day. Of course, some may be with or without evidence. And so progesterone use cuts across the gynecological practice, both outside pregnancy, fertility-related, especially following IVF, and even pregnancy support, especially the early phase of pregnancy, as well as other pregnancy-related challenges such as miscarriages that we may need to support. And so in this conversation for today, it would be important for us to acknowledge that the evidence exists. The practice that we continue to do has to be shaped by that evidence, but the evidence keeps evolving. And so let's not be too shocked when some of the information that is coming up actually probably shakes or changes the practice that we do. But it would be a good idea to equally hear from you, share your thoughts on the chat box. Your perspective, I see in the call, are quite respectable fertility specialists on the call. And so it would be very good and great to hear what your thoughts are, even as we proceed. You'll allow me to remove my video just for process of getting my connectivity better. So if that happens, please don't be shocked. So right, just confirming that I'm able to move my slide. Okay. So what are we looking at this evening? Are we looking at having a better understanding on the basics of progesterone production, a little of physiology, but then recognizing deficiency and application of macronized progesterone becomes probably our main conversation of today, and looking at what is the guideline that's available. And so why is progesterone important, or so one would want to ask? And being practitioners, and I also acknowledge that we have a few of us who on the call who are not gynecologists, and so the language will probably used to be a more simplified version. But it's important to acknowledge that progesterone is critical for the embryo implantation, pregnancy maintenance. We remember that following ovulation, corpus luteum provides our main source of progesterone, whose main role has been to assist or to help or regulate the inner lining, the endometrium, to mature up and be ready for receiving the potential embryo that's awaiting. And so in that process, if conception fails, then the inner lining that had been prepared and matured up by the progesterone work will be washed out or sloughed out in the form of menstrual flow. If a pregnancy happens, then progesterone plays a very important role in maintaining that pregnancy. Progesterone equally plays a very critical role in maintaining endometrial receptivity and supporting placental development. And the aspect of receptivity is a critical aspect that the fertility team actually relies on, especially when doing IVF and related interventions. To reduce uterine contractility and promote uterine quiescence, a very important role, especially where we've had concerns like threatened miscarriage, where we have a patient who has had probably 1 or 2 previous miscarriages, and they're presenting probably with spotting and vaginal bleeding with an intact pregnancy, as we are going to see moving forward. There are instances where we also used it to promote uterine quiescence, where there is significant risk of preterm birth. And we've also applied it in cases where there is uterine fibroids coexisting with pregnancy, and you want to promote uterine quiescence. It has also been applied. Progesterone facilitates maternal-fetal immune tolerance, a very critical aspect of pregnancy journey. It also supports normal reproductive function and successful pregnancy outcomes. This slide is probably not for the gynecologist who's practicing or the medical doctor who is in the call, but just for some of us who may not be in that level of understanding. And we appreciate that progesterone is a key sex hormone that regulates menstrual cycle and has been said before, supports pregnancy, affects mood, and largely produced by the ovaries, placenta during pregnancy, the adrenal glands, and even the CNS. We have no reason not to understand what the placenta is, but we are mentioning it here as it is one of the main source of progesterone during pregnancy. Of course, I've mentioned the corpus luteum before in the previous slide. It's a temporary yellow structure in the ovary that forms after an egg has been released, after ovulation has happened. And it helps in making hormones that would be relevant, especially the progesterone, in sustaining and maintaining the pregnancy. So where is this progesterone met? One would want to ask. And as I said, we are going to look at just basics of the physiology, the overview. And the principal glands that form progesterone are largely the ovaries, the placenta, the adrenal glands, and of course, other body organs also play a role in this journey. In the ovaries, what happens? As I've mentioned before, following ovulation, and that basically means the follicle, the mature follicle, the Graafian follicle rupturing to release the egg. The remnant cells quickly undergoes a modification that makes them become the corpus luteum, which then becomes our mainstay source or production source of progesterone. And once the progesterone is produced, it's a hormone. Of course, it's blood-bound and binds to the progesterone receptors, where it then evokes responses either through intracellular processes or by directly attaching into the receptor on the surface of the cell and evoking non-genomic processes that results into its effect. Of course, after doing its job, or it has not been utilized, it ends up being metabolized and excreted accordingly. We have a very important cycle in the woman's body. The hypothalamic, pituitary, and ovarian axis, the HPO, which is the key regulator for female reproductive system. Of course, beginning right from the brain to the ovary and the after ovary actions of the progesterone, of course, with a feedback loop. And so in the hypothalamus, you have the initiation of the hormonal cascade with the GnRH produced in a pulsatile manner. And this then would cause stimulation of the pituitary gland to form the GnRH, to form the anterior pituitary gland to form the important hormones of the FSH and the LH into the bloodstream. Each of them plays a very critical role. And for the team on the call who understand the reproductive hormonal cascade, then we appreciate how the FSH plays a role in stimulating the growth and maturation of the ovarian follicles, while the LH coming in to trigger ovulation and supporting the corpus luteum, which then produces the progesterone, which is the hormone of interest today. Okay? And of course, the two critical hormones of interest are the estrogen and the progesterone we are talking about, where the estrogen is produced by the developing follicles and the progesterone, as we've said before, being produced by the corpus luteum following ovulation, right? And these two hormones plays a very important role in providing a negative loop or a negative feedback, both to the anterior pituitary gland as well as to the hypothalamus in terms of regulating or reducing the continued stimulation, so that we have estrogen and progesterone regulating the hypothalamus and pituitary gland to maintain a hormonal balance. So we appreciate that progesterone basically works in multiple body organs. And just to mention a few, we've talked about breast, promoting development of the lobules and the alveoli. And of course, this is in preparation for lactation. Pregnancy, maintaining the endometrial lining and supporting the implantation, and reducing contractility and maintaining of the pregnancy are critical elements or roles of the progesterone. We could have deficiency, and we must acknowledge that progesterone works beyond just the role in reproduction or reproductive system, and plays a role even in maintaining mood, that's the CNS activity, bowel functionality, even our supratentorial functionality becomes very critical things. So the deficiency of progesterone then, therefore, would have very non-specific and cross-cutting symptoms, which include the bowels, liver, thyroid, stress, things like migraines, weight gain coming in, and sometimes may not even be possible because to identify that is actually progesterone deficiency because of the non-specific symptomatology. But of course, things like age, especially in advancing age, stress, smoking, alcohol have been known to cause progesterone deficiency. Okay. We agree that progesterone has been applied in several clinical indications, ranging from contraception to infertility, to irregular menstruation, or irregular bleeding, recurrent pregnancy losses, and threatened miscarriage. And these are just highlights, some of the examples where progesterone actually could be applicable in our today practice of gynecology. We will do, for purposes of the non-gynecologists on the call, do a quick insight preview just to what these terminologies mean. Then we can get into a bit of what does researchers say in the application of the progesterone in this particular clinical indications. So we talk of miscarriage when a pregnancy comes to an end before viability. Internationally, it's been 20 weeks. And so in the miscarriage categorization, we have various types. And for purposes of this talk, threatened miscarriage then becomes a scenario where one is pregnant before the viability stage and presents with vaginal bleeding. And this may be associated with or may not be associated with abdominal cramping pain. All right? The term habitual miscarriage probably has been changed to more of recurrent pregnancy losses, where you have spontaneous termination or spontaneous miscarriages that are happening 2 to 3 occasions successively, and these occurring before viability stage is achieved. We acknowledge that once a pregnancy occurs, our desire is to have a term pregnancy, which then would enhance or rather ensure much improves chance of the neonate surviving, minimizing the chances of newborn admissions, and of course, newborn challenges that comes with prematurity. So preterm labor occurs before 37 weeks. 37 weeks becomes our cutoff for term gestation. So if labor occurs before 37 weeks, we say that's preterm labor. And of course, our desire is to minimize this from happening. And there are multiple modalities that we've been able to, that are available at our store, in our store, to be able to make, one, to identify the woman who is at risk of developing preterm labor. Two, measures that can be put in place to prevent preterm labor and preterm delivery, for that matter. And among those measures that exist would be use of progesterone. Okay. So generally speaking, progesterone in terms of clinical application exists in two forms, and that is micronized progesterone and the dihydrogesterone. Micronized progesterone, effective for luteal phase support, especially in assisted reproductive technology, where it's been shown to improve clinical pregnancy rates, and also been very useful in supporting early pregnancy by reducing the risk of miscarriage in women with threatened or recurrent miscarriages. Well tolerated physiologically, and multiple high-quality RCTs and meta-analysis actually support its safety and efficacy, including in pregnancy. This is vaginally administered progesterone. The micronized aspect increases its surface area that really makes its absorption and bioavailability very useful, and therefore improving its clinical application in the areas that have been mentioned. The dihydrogesterone, equally being used as an effective adjunct in threatened miscarriage. Benefits in recurrent pregnancy losses has been shown, been effective equally in luteal phase deficiency, and supported by multiple RCTs. Of note is comparing the vaginal and the oral. Dihydrogesterone is an oral molecule, progesterone. There has been thought that micronized progesterone actually would have a stronger evidence in supporting pregnancies and a stronger safety profile. In the practice, both have been used to support pregnancy. And so the guideline recommendation that supports this micronized progesterone and dihydrogesterone is cutting across from the H3 guidelines to NICE guidelines, FIGO equally. And so strong clinical evidence as well as international guidelines support the use of micronized progesterone, especially for key women health indications, especially in pregnancy-related indications, but also dihydrogesterone in other indications that are pertaining to modern gynecology. Allow me to mention a few specific areas where progesterone has really played a big role and gains a lot of support and has been indicated even in the international guidelines as indicated, is recurrent pregnancy loss, which we're referring to loss of 2 or more consecutive pregnancies. Of course, you go to literature, you'll appreciate that various guidelines refer to recurrent pregnancy losses a bit differently. Others are referring to 3 consecutive or 2 consecutive. And others are also mentioning that they don't have to be consecutive pregnancy losses as long as there are 2 or more in number. And various causes exist for RPL. Among them, genetic factors, which could be either embryonic or parental. Embryonic in the sense that they are not inheritable. These genetic factors, genetic errors are not inheritable. And so they are embryonic based on the process of fertilization and genetic mixing. Anatomic abnormalities could cause recurrent pregnancy losses. Okay. Endocrine metabolic disorders comes in, immunological factors, thrombophilias, and there's a proportion of RPL that are unexplained. Allow me to mention that unexplained in this aspect, most of the time in our setup, is because we've not been able to comprehensively evaluate the couple, which may include need for things like DNA fragmentation for the man, karyotyping, trying to understand what is really behind the recurrent losses. When we reach a stage where we are not able to exclusively do evaluation, oftentimes we say unexplained. Yes, there are those that we may not be able to get an answer to. So what would be the role of progesterone in this particular component of clinical case? The progesterone would be essential for improving endometrial receptivity and implantation, as we've mentioned before. Could be useful for uterine quiescence and reducing contraction of the uterus. And hopefully this would help in sustaining a pregnancy right from a first trimester, supporting early placental development, modulating immune response, and promoting maternal-fetal tolerance. And of course, progesterone supplementation may improve pregnancy outcomes in these women. It's important to mention that progesterone just becomes one of the clinical intervention that we use to support women who have had recurrent pregnancy losses, among others, which may be beyond the scope of this conversation. So progesterone supports a very pivotal role in the evaluation and management of women with recurrent pregnancy losses. I mentioned about preterm birth, and preterm birth follows either spontaneous preterm labor that, despite all the efforts put or lack thereof, we have preterm delivery. And this could either be, of course, I've said spontaneous, but could also be iatrogenic, where for various reasons, especially maternal and sometimes fetal, the doctor is forced to initiate preterm birth. Okay? Now, our interest for this discussion are for the spontaneous preterm births. Among the risk factors that we, of course, know include prior preterm birth. So history of preterm birth becomes a very important risk factor for preterm birth in subsequent pregnancies. Multiple gestations, short cervix, less than 2.5 centimeters as a cutoff, which may then require support, right, to be able to hopefully prolong subsequent pregnancies to reach term. Progesterone then becomes important here in maintaining uterine quiescence, supporting cervical mucus plug, and reducing the risk of preterm birth. And if you look at some of the literature that we are going to look at, maybe subsequently the guidelines, short cervix, prior preterm births, and especially if we can get to understand the clinical basis of previous preterm births, if it is because of cervical insufficiency, there's a role for sacrilege, and there's a role for progesterone utilization. Remember, why do we want to prevent preterm births? Because premature babies or preterm birth contribute to the largest perinatal and neonatal mortalities and morbidities. So as much as possible, it's something that we really want to prevent. Following embryo transfer, and probably at the end of my talk, I'm going to invite one of our fertility specialists to probably make a few comments in regards to ART, infertility, and progesterone use, maybe in 2 or 5 minutes. ART and luteal support requires progesterone application. Of course, we understand we are coming from various reasons why we would want to apply the ART. We may require ovarian stimulation, fertilization and embryo culture happening. Then you have embryo transfer. from the time where we are harvesting the eggs, during the embryo transfer and the early phase of pregnancy, progesterone support is important. And so the endogenous progesterone production may be inadequate in some of the ART cycles. In fact, it's almost a routine that due to the risk of implantation failure and early pregnancy losses, progesterone support by using exogenous progesterone becomes important. So that progesterone support becomes critical for restoring optimal luteal phase and supporting implantation, maintaining early pregnancy by the mechanism that we've mentioned earlier. So adequate progesterone is essential for us to ensure endometrial receptivity, encourage implantation, and maintaining that pregnancy, especially in the first trimester. And so luteal phase support with progesterone in ART cycles significantly improves implantation and achieving live births. So we've mentioned a few areas where micronized progesterone, dihydrogesterone are applicable. We've looked at the basics of what they mean and how the progesterone would be critical in their support. So there are a few technological aspects that have really been able to help and improve bioavailability as well as safety of progesterone and its utilization. So on the left, you have quite large standard particles, just graphically. And then you have a scenario where you break these particles using the micronization technology to make them much, much smaller. What does that do? You basically enhance the surface area that is exposed to the dissolving medium. And that micronization enhances the solution, which then improves absorption. And that comes with improving bioavailability, which then is what gives us higher serum levels that is able to meet the clinical threshold required to achieve the objective we want to get. So the micronized progesterone really becomes an enhanced technology that improves dissolution and bioavailability. And that makes this molecule be much more available following vaginal administration. We've looked at this mechanism of action, but just for purposes of reminding ourselves. So the progesterone then attaches or binds to the progesterone receptor and activates gene transcription. And that is the genotypic way of its action. Of course, you also have direct action as well. But the gene regulation that happens, you have modulation of the target gene expression that then results into cellular changes based on the information provided or rather initiated by the progesterone attachment to the receptor. The end goal of all this gene regulation and promotion of the cellular changes as a result is then to ensure endometrial maturation by enhancing secretory activity within the endometrium and increasing vascularization. Right? And this really does what we've been talking about, maintaining endometrial stability, inhibiting uterine contractility, achieving the uterine quiescence, which are very important for the pregnancy maintenance. Is there any supporting evidence to this? Is there any guidelines that support use of progesterone? And the answer is yes. Various international guidelines support use of progesterone. In ART, in early pregnancy, in miscarriages, threatened miscarriage, as well as in recurrent pregnancy losses. Allow us to mention just a few. So the Lockwood et al., an RCT that involved 656 participants, the end outcome of this study was that subcutaneous progesterone compared to the vaginal progesterone gel for ongoing pregnancy rates in IVF cycles. The subcutaneous one were actually non-inferior to vaginal, supporting that we could actually use both subcutaneous progesterone as well as the vaginal progesterone gel. And following that, you have Sato et al. In 2012 looked at subcutaneous aqueous progesterone utilization and compared it in terms of its overall bioavailability. What did we achieve? That aqueous progesterone achieved faster time to peak and higher peak levels compared to IM or intramuscular oily formulation with comparable overall bioavailability. So as much as, yes, there's a quick peak or higher peak levels, but in the overall bioavailability, you still have the IM oily formulation still providing the required level. The RCT by Ziegler et al., the endometrial transformation that is achieved was noted to be almost 100% of women who received subcutaneous aqueous progesterone for luteal phase support. These are just but some of the clinical trials that have existed. Of course, there are more clinical trials that have been done. PRISM, for example, that we are going to look in subsequent slide. And as a result, a few guidelines have actually come up. And I know these guidelines are constantly changing, being updated based on evolving evidence as more and more clinical trials are happening. And so the latest HTA guideline 2023 recommends that progesterone should be used for luteal phase support in ART. And this may improve the live birth rates. Of course, multiple routes have been considered acceptable: vaginal, intramuscular, subcutaneous, based on the various formulations that exist. The American Society for Reproductive Medicine equally, in its 2021 guidance, supports the use of progesterone for luteal phase support. Of course, for them, a bit more lenient and allows for individualized based choice of the route of administration based on preference of the patient as well as tolerability. Same applies to the Royal College of Obstetricians and Gynaecology, which supports progesterone supplementation in early pregnancy for women with recurrent miscarriage. And the NICE guidelines also support use of progesterone supplementation in women who have had with threatened miscarriage, especially in those who have had one or two previous miscarriages. And so from this, we're basically saying that there's strong clinical evidence and guideline support for use of progesterone. And this includes various formulations: vaginal, intramuscular, subcutaneous, for effective luteal phase support and early pregnancy care. A lot of conversation has happened around the safety, especially for the mother and for the unborn baby. And especially micronized progesterone is passing a lot of safety checks. And though we may have a few reported concerns, especially with dihydroprogesterone, especially in for the early phase of the pregnancy for the baby, very small proportion, probably less than 5%. And I'll probably be inviting one of our senior colleagues to maybe make a comment on the same. So maternal safety for progesterone, exogenous progesterone, is generally well tolerated. Well tolerated. The subcutaneous administration has some advantages. The same applies to intramuscular as well as vaginal to some degree, that they avoid the fast pass metabolism. Remember, the molecules we take orally, absorbed via our GI system, their first place they pass through is the liver. And the liver does what it does best. So the fast pass effect results into reduction in the amount of the molecule that's available in the body system. And that reduces the bioavailability. So the subcutaneous administration and other non-oral options then improves bioavailability and also reduces local adverse reactions. Okay. Established safety profile. It's important to note, as I've mentioned before, that in terms of clinical practice, both for gynecological and maybe non-pregnancy related and pregnancy related, largely extensive safety profile that has been clarified are largely favorable. Same to the fetus. Large clinical experiences and studies seems not to suggest any increased risk of congenital anomalies. Of course, there's current discussion going on about the dihydroprogesterone, but the risk is quite small and it is an evolving field. We've used it quite a lot and has been probably one of the mainstay progesterone choice that we've been able to use even in our country. Progesterone supports implantation and the maintenance of pregnancy without harmful effects on the fetus, generally. And clinical trials and real-world data demonstrate safety, right? Of course, it's important to mention that even as we acknowledge these safety positions, we must keep alert. We must keep aware that more data is being generated even as we continue to use them. And so we still have to be aware that it's possible to have reports, and those reports have to be analyzed to its detailed end on how do we associate any adverse fetal outcome to the molecule that has been used, in particular in this case being the progesterone. Progesterone therapy for luteal phase support has a strong track record, generally speaking, and has strong maternal and fetal safety when used appropriately. So appropriate use becomes an important aspect or component of the clinical practice. Early pregnancy bleeding has in quite a good proportion of our pregnancies, 20 to 30%. And while majority of vaginal bleeding in early pregnancy could either be because of implantation bleed, others actually threatened miscarriage, but most of them actually resolves spontaneously. And so follow-up, monitoring, conservative management would actually suffice. But it's also important for us to take note that miscarriage risk is higher in a woman who has bleeding in early pregnancy. And so in that background, the PRISM trial then assessed whether progesterone would improve live birth rate in women with early pregnancy bleeding. And so there's a comparison of women who have had previous miscarriages and women who had no previous miscarriages in the sub-analysis. Because in the overall analysis of this study, there was no significant difference in live birth rate with progesterone versus placebo. there was no significant difference in live birth rate in women who had vaginal bleeding in early pregnancy compared if you gave them progesterone and compared it with placebo. However, in further analysis that looked at women who had previous 1 or 2 miscarriages and more than 3 or 3 and above, compared to no previous miscarriages, differences were becoming substantial. If you look at the middle column, no previous miscarriages, progesterone use versus placebo, there was no benefit. Where you had 1 to 2 previous miscarriages, about 76% had live birth rate following progesterone use. And those who had placebo, we had 72% of them getting a live birth rate. So some benefit. Was it significant? No. 3 and above, then there was a substantial benefit. And so based on this PRISM study, a number of guidelines, just NICE, actually now recommends that we may offer vaginal micronized progesterone, and the recommended dosages is 400 milligrams twice daily to women with an intrauterine pregnancy confirmed by the scan, a transvaginal scan preferably, if they have vaginal bleeding and they have previously had a miscarriage. It's important that when we get a fetal heartbeat present, as we do our TVS, we should be able to continue this progesterone until at least 16 weeks of pregnancy. So that was quite a very clinical practice determining outcome that formed the practice guideline changes, has been mentioned. And so looking at a clinical case example, this purposes of trying to put it into perspective and practice, that if you are to have a 32-year-old woman coming to us who is gravida 4 and has had 3 previous miscarriages, presenting to us with vaginal spotting at about 6 weeks plus 2 days, we managed to do evaluation. The patient is stable, hemodynamically stable, no active bleeding on evaluation speculum, and a transvaginal scan confirms an intrauterine gestational sac and fetal pole present and a fetal cardiac activity noted. What would we offer among other clinical interventions? Of course, it's important to mention this does not mean this is the only intervention we are going to give. It has to be individualized. The key factor here is the fact that this patient has had 3 previous miscarriages. Okay? So what would be the advice? Based on the clinical guideline, vaginal micronized progesterone would be used or maybe offered in this patient. 400 milligrams vaginally twice a daily. And this should be continued until 16 weeks of pregnancy. And this is based on this RCT support, the PRISM trial. So progesterone does not benefit all women with early pregnancy bleeding. I know our current practice has been any woman coming to us with vaginal bleeding, progesterone is provided. But we are saying, while that could be our normal practice, the current international guideline suggests that progesterone may not be of benefit in women who may not have had previous miscarriages. But for those who've had previous miscarriages, then it is beneficial. And it is most beneficial in those with a history of recurrent miscarriages, especially 3 and above. Right? So, as we near public closure, early pregnancy bleeding and miscarriage. We've looked at the PRISM trial. We've looked at the guidelines recommendation, which was basically NICE as updated in the 2026 June. It's also important that we relook at preterm birth prevention, where we are saying the RCTs that have been done, double-blinded, randomized, placebo-controlled trials using vaginal progesterone, amongst women who are at risk of birth due to previous spontaneous births below 34 weeks, and cervical length less than 2.5 centimeters or 2.5 and below, and there's a positive fetal fibronectin test with other risk factors, these women, we may offer them progesterone support right from early pregnancy. The three cardinal factors that puts a woman at risk of subsequent preterm birth, when considered, there's a role of progesterone application. Further, and just to, again, emphasize the same information we've talked about, case summary of a 28-year-old Gravida 2, para 1, at 8 weeks, has mild vaginal bleeding, bright red in color, associated cramping pain. The cervix is closed, and the uterus remains soft, though enlarged, but consistent with the dates. Scan confirms in utero embryo, 8 weeks, basically in keeping with the gestational age. Fetal heart tones present, and there's a small subchorionic hemorrhage. We've done beta HCG, we've done progesterone levels, and they're within the normal limits. There is room for watchful waiting, bed rest. We may want to have a shared decision on use of progesterone support for this patient. So, what would be the practical recommendation? When do we prescribe? How much? Duration? And what kind of counseling are we providing? So we talked about luteal phase support in ART treatment. We talked about maintenance of pregnancy in threatened or recurrent miscarriages. We've talked about application of progesterone in treatment of menstrual disorders due to progesterone deficiency. Of course, we can also use progesterone in secondary amenorrhea, as well as endometrial protection during estrogen therapy to prevent hyperplasia and malignancy development for the endometrium. So what are the general guidance for the dosages? For micronized progesterone, 200 to 400 milligrams per day. Okay, can be given vaginally or orally. There is inconclusive literature about which one is more effective, but the general understanding is where possible, vaginal option gives a better outcome. Inconclusive debate about that, though. Of course, 400 milligrams vaginally for luteal support, luteal phase support in ART. And I know the Renata team are going to talk about the dydrogesterone and the micronized progesterone that are specific to them and be able to mention the specific dosages that we'd want to be able to apply for these cases. If you are doing luteal support in ART, it's advisable that we continue until 12 weeks of pregnancy or as advised. Same to threatened or recurrent miscarriage. And remember, in our previous conversation, we said where there's fetal cardiac activity and you're dealing with a woman who has had threatened miscarriage in the background of multiple pregnancy losses, 3 and above, then we might want to continue with this for up to 16 weeks. Okay. So when talking to the patient, it's important to discuss the importance of regularity, compliance, or adherence. Stopping the medicine abruptly, especially for where you're having irregular menstrual disorder, then may result into recurrence of the same symptoms or bleeding happening. So not stopping the medicine abruptly becomes something very important. Reporting any bleeding or discomfort that may arise, and of course, maintaining receipt follow-up. And more importantly, mentioning the importance why you are giving this particular molecule to that patient. Is there an evidence or support that would make us suggest that particular treatment? Our patients are beautiful humans. When you engage them and you have a shared decision-making, you actually have a very easy way of going through with them. So, progesterone is essential, and deficiency may have major reproductive and even non-reproductive consequences. And exogenous progesterone has evidence-based clinical uses. So let's support our women to be able to achieve better outcomes. All right. Ladies and gentlemen, with that, allow me to take some 5 minutes just to invite a senior colleague of mine in the fertility field. Dr. Witi, you probably want to take a few minutes just to share one or two thoughts around use of micronized and dihydrogesterone, especially in fertility-related space. Dr. Witi, I don't know if you can hear me.
Yes, I can.
Over
I don't know
to
if you
you.
can hear me.
Loud and clear.
Okay, thank you, Dr. Amenge, and that was a fantastic presentation. And thank you to everyone. I think as gynecologists, progesterone is one of those things we have all used, whether in small doses, big doses. And I always make fun that we've been in school you did 6 years of postgraduate, and now you did 6 years of undergraduate and 4 years of postgraduate. That equates to 10 years, not forgetting internship and 2 years to get your specialist recognition, all working out to about 13 years to become a licensed gynecologist, to just write one drug, but give it in different ways to achieve a different effect. You want bleeding, you give progesterone. You want to stop the bleeding, you give progesterone. You want to have a baby, give progesterone. You don't want to have a baby, give progesterone. So it's a very interesting drug that we went to school for 10 years to just prescribe one drug, but it's a fantastic molecule in whichever form that it is. I think in the fertility space, we are more partial to parenteral routes of progesterone. So that would be the micronized progesterone. I know there are those of us who say that micronized progesterone, they have formulations which are absorbed easily, but I'm from the school of thought that micronized progesterone should always be given parenteral in as much as it can also be given in an oral form, so that you really get the real benefits of progesterone. So it's just a wonderful molecule for us. Our mainstay is the luteal phase support in IVF, and currently the recommendation is about 400 milligrams. We give it twice a day. If we're doing a fresh transfer, it is following the day when we stop. The moment we've done from the day of pickup, and we continue. If we're doing a fresh embryo transfer, we're going to depend on the age of our embryos. We always give it the age of the embryos +1. So if I have a 3-day embryo, which we're going away from, I'll give progesterone for 4 days, and on the 4th day of progesterone therapy, we're going to do our transfer when giving progesterone. interestingly, we've been to many conferences, and you find that even molecules like dihydrogesterone, so you find like until recently, I don't know about now, you have countries like West Africa, whereby cold chain was an issue, getting things like micronized progesterone, because again, you really have to maintain a cold chain in terms of storage, was difficult for them. Dihydrogesterone was oral, and they found that they have very good results with dihydrogesterone. I know at the moment dihydrogesterone is also being implicated for congenital malformations, but it's a slightly higher risk. I think it's about the relative risk is about 5 as compared to micronized progesterone. So people are being more cautious about dihydrogesterone, but it is a molecule that some of our colleagues in West Africa have used exclusively, and probably they should publish on what their rates of congenital anomalies are, so that we can just get an overview of that. But other than that, I think it was a fantastic presentation. As with the progesterone, we're progesterone team progesterone Damu, and would recommend everybody who I'm sure everybody in this meeting is also using progesterone. So I thank you so much, Dr. Amenge, for giving all your insights and on other uses as well. I think we all know most of us are doing also general gynecology, so we do use for other indications. Thank you so much.
Thank you so much, Dr. Witi. Thank you so much, Dr. Amenge, for those insightful thoughts and thought-provoking presentation. Before we go into the questions, and also to give Dr. Amenge a moment to just have a glass of water, I'd like to to invite Niloy Kabir from Renata to just tell us one minute or 2 minutes to just tell us something about their products that are within the women's health space. For now, please keep sharing your questions and comments. We are seeing all of them, and then we jump back to the questions.
Thank you very much, Dr. Mutabari, ma'am. So thank you for allowing me the floor. So I would request everyone to stay, not to leave, because I have to tell something 6,000 kilometers away from you. So in a small country from Bangladesh. So first of all, I would like to thank Dr. Amenge for the excellent presentation and for sharing those valuable clinical insights. Especially, he beautifully presented about the use of progesterone in our body, the activities of progesterone, and especially the micronized progesterone. This technology is very important now when we are offering medicine to our patients. So just to briefly introduce myself, I am Rizwanul Kabir Niloy from Renata PLC's international business team. So it's a pleasure today to be here and to have the opportunity to briefly introduce Renata and share our plans for the Kenyan market. So far, Dr. Amenge has been, describing us about the progesterone. So we have a progesterone portfolio to offer to the Kenyan people, and I will be talking about the two products that we are going to offer, which consists of progesterone. Before that, I will also take this opportunity to say something about Renata. Like if we say about Renata, we have been present in Kenya for more than a decade now. And over this year, we have been committed to bringing quality and affordable healthcare solutions to patients. Globally, Renata has grown significantly and is currently present in more than 70 countries. So we also have subsidiaries in the UK and Ireland, reflecting our growing international presence and our commitment to meeting global quality standards. So as part of this commitment, we are continuously expanding our portfolio in areas where there is a clear clinical need. So as of today, I would like to highlight our progesterone portfolio consisting of Refaston, which is dihydrogesterone, and Microgest, which is natural micronized progesterone. So Refaston contains the dihydrogesterone, as you all know already. It's a very generic molecule now. And this is actually a synthetic progesterone. which with established clinical experience in progesterone support. So I think you already, some of you are using Dupastone, or you heard about Dupastone, which is the originator brand. So we are bioequivalent to the originator brand. That means our Refaston gives the same efficacy and safety profile as the originator brand is. So this is one of Renata's specialty, that whenever we launch a molecule, we especially in the women's healthcare portfolio, we recommend it to be bioequivalent, because this is the only standard that can be followed and to maintain the highest quality to offer the patient globally. So you can consider our Refaston as bioequivalent to the originator. So with the quality ensuring with the same efficacy and safety profile. So on the other hand, Microgest, as you can see in the picture, we have two strengths, 200 milligram and 400 milligram. So it contains the natural micronized progesterone and provides a natural progesterone approach to the patients. And we are offering both the oral and vaginal presentations available for the patients to be consumed. So if we go to the next slide, the key message is very simple. So progesterone plays an important role in reproductive health, but every patient may have different clinical needs. So therefore, having more than one therapeutic option can help physicians make the right choice for their patients. With Refaston and Microgest, Renata is offering physicians two trusted progesterone options under one portfolio, supporting our broader commitment to women's health. We are very excited to introduce these products to the Kenyan market and look forward to working closely with our doctors and the medical community to make them available to the patients who need them. So thank you once again for your time, and we look forward to working together to make this launch a success. So thank you very much, everyone.
Thank you so much, Niloy. We have a number of questions that have been coming in, and I would like to share these questions out between Dr. Amenge and Dr. Witi. Now, one of the questions, Dr. Amenge, during the presentation, you mentioned that one mode of administration of the progesterone can be intramuscular subcutaneous. From what we currently know is that the one intramuscular formulation that we knew was the 17-hydroxycaproate, I stand corrected, which was formerly known as Makena. And it has since been withdrawn by FDA after it was found to be not as effective, if I can say that. And one of our meeting attendants is asking about the formulation of the intramuscular progesterone. And given that most of the studies you've presented are showing that the vaginal micronized progesterone is preferred, in which cases and instances will we then be required to give the intramuscular or subcutaneous progesterone? And in such cases, the patients taught to self-administer, or do they have to come in weekly for the injections? That will be the first question. Just allow me to combine a few questions that are telling towards the same thing. Then we think that the studies were suggesting that we could use the progesterone up to about 16 weeks of gestation. And there's a question as to what is the rationale behind stopping it at 16 weeks. Yes, Dr. Amenge, please go ahead.
So thank you. Thank you for that great question. Now, if you look at most of the studies recommends cause use of vaginal and oral formulations. Subcutaneous progesterone have equally been provided as alternatives. And likely the choices are based on patient preference and tolerability, and of course the clinical indications as well put. Subcutaneous micronized progesterone is used largely in the ART, as well as in early pregnancy, of course, support, and continued until around 10 to 12 weeks of confirmed pregnancy. For threatened miscarriages, where you have more than one previous miscarriages, The guidelines suggest that we go up to 12, others even up to 16 weeks. The question is, what is the rationale to this? We're looking at when is the placenta fully taking over that role of progesterone production, the endogenous progesterone adequacy. So in the ART, for example, and probably Dr. Witt will be able to make a comment on this, that being her main field, you want to start, whether you're using the vaginal or you're using subcutaneous micronized progesterone, actually you want to begin it on the day of either the egg retrieval or right around the embryo transfer. And as said again, continued up to around 10 to 12 weeks of pregnancy once the beta HT is positive, rather is confirmed. In terms of how to do the tapering, I think that would be individualized and based on the fertility specialist guidance. Also, in the threatened miscarriage, I've mentioned the same, that we initiate it the first sign of vaginal bleeding during the early first trimester. And this is maintained until 12 weeks when the placenta fully takes over the progesterone production. Of course, as I mentioned, like NICE guideline recommend that you may want to consider extending this up to the 16 weeks gestation. So for subcutaneous administration, yes, if the patient is able to do self-administration or be advised to go to the nearest facility where this can be done, it is advisable. So again, you're also reducing the burden to the patient, but not every patient will be able to do this self-administration. I hope that is able to make some clarity on the question that has been asked.
Yes, thank you, Doc.
Probably I can chip in.
Yes, Dr.
Yes.
Witt, please go ahead.
So a lot of research has been done, like for specifically like luteal phase support. And interestingly, on luteal phase support, it has been found by about 6-7 weeks, placenta has actually fully taken over the hormonal production. The placenta has taken over the hormonal production of progesterone, and we actually do not need it. So we are actually told by the time you see the heartbeat, you actually don't need any more progesterone supplementation if the issue is luteal phase support. But remember, there are other issues that do occur. So, and like, for example, I think Amenge talked about subchorionic hemorrhages. And what does that do? It makes the uterus irritable and it wants to contract. So if you want the uterus to relax, your drug of choice is obviously going to be progesterone. And we know that progesterone is responsible for quiescence of the uterus. So you would want to have that benefit added to the patient. 16 weeks, like with most medications, when they come in, people just maybe arbitrarily decided that this was what was going to happen. And you have to come up with studies to show that whether it's 12 weeks, 4 weeks, 5 weeks is sufficient. And until somebody does that, we are stuck with the 16 weeks. I hope I've shed a bit of light. Thank you.
We are stuck with the 16 weeks until we get a difference. Well put. Thank you. Over to you.
Thank you, Dr. Witi, for that, and Dr. Amenge. Now, Dr. Witi, one of our guests in the meeting is asking about the role of IM progesterone in IVF preimplantation in frozen embryos. And still around the same question, because I want you to tackle all your questions at the same time as well. My question becomes, is there a role of routinely measuring progesterone levels in our patients? And if we do get to measure the progesterone level, what is the threshold below which we should intervene? And in case we do find that this progesterone level is low, should we then automatically increase the dosage of the progesterone supplementation that you're then giving?
Okay, thank you, Mutabari. Those are very interesting questions. And interestingly, in ART, you're actually more worried if you have high progesterone before the time you want to do either your trigger or especially if you're doing a fresh embryo transfer, because it means you will have a lining that is not in sync with your embryos. your lining will be ahead of your embryos. In terms of low progesterone levels, that is good because we have the work of the micronized IM oral progesterone. We just supplement, and it should be able to give you a good outcome. So we're actually worried more for us if we have high progesterone levels. Like if I find I have high progesterone levels on the day of oocyte pickup, I think the threshold is 4, above 4, then it means that I would actually opt not to transfer those embryos in a fresh cycle. I'd opt to freeze and transfer in a subsequent cycle so that I don't have my embryos being put in a lining that is too advanced for the embryos themselves. So low progesterone, don't worry, just supplement. There was another question, Mutabari, there was something I can't remember about IM, whether you use IM oral. Again, a lot of research has gone into this, whether you're going to use, or you can use oral progesterone on its own, you can use micronized progesterone on its own, you can use IM progesterone on its own. So it's a matter of what is the protocol in your unit for IVF. So you find some units, they used exclusively micronized progesterone. You don't need any other progesterone if you're using micronized progesterone at the correct dose. If you're using IM, again, you must remember, especially if it's the IM progesterone, it's oil-based, it is painful. What some of us do, because I think you've seen some of our prescriptions, is that we take advantage of the micronized progesterone and the IM progesterone so that you ensure your local levels, like your micronized progesterone is going to give you very high concentration locally at the level of the endometrium, which is where you want. But you may also want that in the bloodstream. You also have high levels of serum levels of progesterone. IM is going to take care of that. So at any given point, but research has shown whichever route you want to use, you don't have to combine the various progesterones. But remember, IM is very, very, very painful. But there were a group of people, I think my mother's age, if you didn't give them an injection, tibu. So you also look at it. What is available in your market? What is the preference, patient preference? What's your clinical protocol? And what is available? Thank you.
Thank you so much. I believe I've tackled all the questions that were on the call. And as we give our closing remarks, I'll just like both Dr. Witty and Dr. Amenge to just comment on if we were to fast forward the five years from now, what frontiers in progesterone therapy would we be looking to explore into, especially because I know we have research enthusiasts on the call. So as you just give us your closing remarks and your final input, just tell us what frontiers in research should we be looking at in the next 5 years, for example.
You want me to go for? Okay. Yes, Dr. Witty.
Yes, sorry.
I think looking at like if I look at our community, a lot of people don't like inserting things in the vagina, and I think we have the oral progesterone which takes care of that. So it's just getting more and more newer and safer formulations of progesterone that would be using an oral route, and probably maybe like long term, like like there's this, like I always laugh, our herbal guys are ahead of us. There's a drug called Mchina. I don't know anybody on the call who knows what Mchina is. Mutabari, do you know what Mchina is?
I know, Doc, I've not even heard of it.
Mchina, you've heard of it. It's just maybe the way I'm putting it. The locals, there's this herbal contraceptive that is used once a month.
Second monthly.
And it comes from China. So when I eat China, from China. So I'm not advocating for the use of Mchina, but I'm advocating that probably if we could get formulations that are like Mchina, one pill you take once a month, na maisha na kazi iendelee. Thank you.
Thank you, Dr. Witi.
Yes.
Dr. Amenge.
Thank you so much, and thanks, Dr. Witi, for those insights. Definitely, progesterone is here to stay with us. Quite widespread application, safety profile acceptable, but of course, the concerns that comes in are for our patients who need this molecule. Are we able to meet their preferences, their needs? Because a patient could be having vaginal bleeding or threatened miscarriage with, of course, previous history of multiple miscarriages or rather current pregnancy losses. And you're asking them to insert this drug vaginally. Then looking at the other alternative being taken oral, then there's the first pass effect on the liver. And so in addition to looking at what can we give that can stay longer, like a depot, can stay longer in the body, and you just do maybe one injection for that period, or one oral medication that can last for a whole month or the period of the first trimester. It would also be important, how do we then overcome the first pass effect, okay, that can enable us to still achieve the bioavailability required, even with the oral alternative. So the technology has to continue evolving to be able to meet these needs. Of course, even the oily intramuscular progesterone, not a funny one at all. So we're able to make it more palatable in the sense of patients not finding it very difficult to consider it. So the technology of the molecule preparation has to gain more traction that meets the woman's needs. Number two would be, I'm looking forward to a state where we can be certain, with certainty, say that these molecules are fully safe to the baby and to the mother. And so I'm looking forward to end to the issues of safety concerns, especially for the progesterone molecules. And my hope is, especially for the Western Africa teams that are using a lot of the oral options, could the data they're generating therefore form part of the research work that they would share with the world and really confirm and not only the effectiveness, but also the safety profile in the practice. So mine would be to say thank you to everyone who has joined the call and joined the rally call that let's give the best to our women, whether it is pregnancy related, whether it is gynecological and pregnancy related. Let's provide the best care and let's make their health highest standard possible. Otherwise, thank you so much. It's been a pleasure.
Thank you. Thank you so much, Dr. Amenge. Thank you so much, Dr. Witi. Thank you to the Renata team for hosting this CME for us. And thank you to every single member who's joined and been a participant in this presentation today. I would like to wish you all a lovely evening. Have a good night.